currently works with the San Francisco Department of Public Health Street Medicine team as the clinical director of HIV homeless outreach and mobile engagement, an intensive case management program for patients with advanced HIV and substance use disorders experiencing homelessness. She's a recent graduate of the Primary Care Addiction Medicine Fellowship through UCSF's Division of HIV, Infectious Diseases and Global Medicine, where she currently serves as an associate physician and volunteer clinical instructor. Her fellowship year was supported by REACH, Recognizing and Eliminating Disparities in Addiction Through Culturally Informed Healthcare, a SAMHSA-funded grant that supports research and training of addiction specialists working with racial and ethnic underrepresented minority patients with substance use disorders. Prior to fellowship, she completed internal medicine residency and studied public health and medicine at Johns Hopkins University in Baltimore, Maryland. There'll be a Q&A session at approximately 9:20 following the talk. If you have questions for Dr. Mehtani, please submit them via the public chat box. And now please join me in welcoming Dr. Nicky Mehtani. Thank you.
Thanks so much for that introduction, Brad. I'll just start the screen share. Okay. And all right. Okay, I think you guys can all see. So thank you all for inviting me here today, first of all. And thank you, Brad, for that introduction. I'll be speaking to you all today about a study I designed and implemented last year called BuPlink, buprenorphine needs assessment and critique at reentry. The goal of the study was to better understand barriers to buprenorphine access among people leaving the San Francisco jails, so really at that point of transition. So a quick roadmap for today. We'll start out with a case that for me served as a motivation for conducting this project. We'll then discuss the background of the issue of treatment of opioid use disorder in jails and prisons more broadly, the specific research aims of this study, the methods, some of our results, and proposed interventions that have kind of been built out of the results of the study, some of which have already been implemented. Okay, so starting out with a case. So this is Mr. CH. Mr. CH is a 32-year-old gentleman with a history of opioid use disorder who presented to the East Baltimore Medical Center. That was my primary care clinic in residency. It's a community clinic in East Baltimore. And he presented one day and he requested to start buprenorphine naloxone for the treatment of OUD. So his HBI, he has intermittently been in jail and prison for about the past 10 years. And most recently, he'd been released from a 5-year sentence just yesterday, the day before he presented. So this is my first time meeting him. All of his prior arrests have been related to drug possession or crime related to substance use disorder of some sort. And while he was in the Maryland State Prison, he'd been purchasing buprenorphine, $20 per a 12 milligram film regularly for the past 3 years from the underground market while in prison. So what he'd do is he would take a 12 milligram film, cut it in half, and take 6 milligrams basically every day. He was lucky enough to have some commissary money and was able to purchase this, quite regularly. So when I was seeing him, it had been about 72 hours since the last time he'd taken 6 milligrams of buprenorphine. And he's currently feeling pretty restless, anxious. His CAL score is about a 4. He'd actually presented to an intensive outpatient program earlier in the morning and then was turned away due to program capacity there. But he was told that he could come into EBMC instead and get a prescription for Bu. So this is a little bit unusual for our clinic. I'd never run into this before. This patient was uninsured at the time due to the Medicaid inmate exclusion, which kind of prevents people who are in jail or prison from having Medicaid, even if they qualify. He didn't have an appointment this day, but everything kind of checked out and it sounded like a good idea to continue him on Bu. So we got a past medical history. He started using opioids at age 18. He'd been prescribed OxyContin for fractures, status post the motor vehicle accident. And after being prescribed medications for a while, he developed physical dependence to opioids and then transitioned to intravenous and intranasal heroin, just for ease of access and the fact that it was more available and cheaper. He previously used a variety of other substances in prison as well. So benzodiazepines, heroin, cocaine. He stopped actually using all of those 3 years ago once he started using the buprenorphine regularly. He's never before had a prescription for buprenorphine, and actually didn't really know very much about it until he heard about it from other inmates in prison. So he's really kind of taught what this medication is about, and he has no other medical conditions. So in formulating his assessment and plan, certainly had a history of severe opioid use disorder. We saw him as an add-on patient that day and decided to prescribe him a week's worth of buprenorphine, gave him a 1-week supply and asked him to return the following week. Because he didn't have insurance at the time, we didn't want him to have to pay for this. So what I actually did was direct him to the PCARE van. So the PCARE stands for Project Connections at Reentry. And this is a van that sits right outside of the Baltimore City jails. So if you remember, he came from prison, but we were directed him to the stand outside the jails where a prescriber sits and basically prescribes people who are walking out of the door from jail buprenorphine, so that they don't have to go use other substances. And when they do that, they give them a voucher to pay for this prescription, knowing that their insurance is not generally reactivated by then. All right, so we don't actually have an audience response system in place right now, but my question for all of you, just to kind of ask yourselves in the back of your minds, is, would you call this encounter a success? So A, yes, during the first 2 weeks after release from prison, the risk of death from drug overdose is 129 times that of the general public. So starting buprenorphine saves lives. B, no, he was doing something illegal by obtaining buprenorphine in prison, and now you're enabling him. C, maybe, it depends on whether he follows up in clinic. Or D, I don't know. So you can kind of just tell yourselves kind of what you think this answer might be. And just to be clear, when I say success, what I'm asking is, was this like a win for our healthcare system? Did I, as a provider who represents our healthcare system, do more good than harm? All right. So I'll tell you guys just, when this all happened, I was personally very pleased with myself. I was toward the end of my internal medicine residency. It's pretty rare during internal medicine to go home from the hospital or the clinic feeling as though you actually did something or prescribed something that almost certainly improves a patient's survival and quality of life. So I thought it was pretty great to see all of the stars aligning for this gentleman. In fact, I was so kind of motivated by his story that I'd been talking to the patient about co-authoring an op-ed together that highlighted his experience, and basically in an effort to demonstrate to the public and to lawmakers why it was kind of ridiculous that they're not already providing treatment for opioid use disorder in the form of buprenorphine in jails and prisons. However, as I started writing this op-ed with him, I kept on kind of getting stuck on this one particular issue in this case that just didn't feel like it added up the way that I was telling myself it was. And so for the remainder of this talk, I'm curious if I can convince you or demonstrate to you all that while answer A is, I think, certainly one of the right answers, in my opinion, perhaps we're missing some things that really need more exploring before we try to depict this encounter as a win for our healthcare system. Okay, so just some background. This slide has no title because I think it basically speaks for itself. So the US employs mass incarceration. Particularly after the 1980s, incarceration rates in our country have ballooned astronomically. There's been some minor improvement over the past couple of years, but we're still by and large the #1 most incarcerated country in the world. Why is this happening? Why are we incarcerating people? Well, since the official beginning of the war on drugs in the 1980s, the number of people incarcerated for drug offenses in the US skyrocketed from about 41,000 in 1980 to 450,000 in 2017. That's the reason that a lot of people will give you drug offenses is why we have mass incarceration. But really, drug offenses, as we all know, is only a very small, tiny part of this story of mass incarceration. What people are really going to jail or prison for in such high numbers really comes down to the color of their skin and ingrained structural racism. So I think this infographic has probably been seen by everybody in the Zoom room already, but I think it's worth reviewing again because it continues to feel just kind of insane. So what it shows is that the lifetime likelihood of imprisonment for US residents born in 2001 was 1 in 3 among Black men, 1 in 6 among Latino men, 1 in 17 for white men. For women, it was 1 in 18 among Black women, 1 in 45 among Latinas, and 1 in 111 among white women. So to quote Michelle Alexander, this is not because Black people are significantly more likely to use or sell illegal drugs than whites, but they are made criminals at drastically higher rates for precisely the same conduct. Another profound quote from her book, The New Jim Crow: "It is no longer socially permissible to use race explicitly as a justification for discrimination, exclusion, and social contempt, so we don't. We use our criminal justice system to label people of color criminals and then engage in all the practices we supposedly left behind." So back to this case, would you call this a success? So let me start by just giving you a little bit more context here. This encounter occurred in Maryland State, which has the highest incarceration rate of people of color nationwide. It also occurred in Baltimore City, where 63% of city residents are Black, and among Black men aged 20 to 30, 52% had active justice involvement. That's a point prevalence, 52%. So 20% of Black men in that age group were in jail or prison, and 32% were on parole or probation. Then kind of zooming in a little bit even more locally to my clinic at the East Baltimore Medical Center, more than 85% of my patient panel was Black or Latinx. And so what is the point of me listing all these numbers for you? Mr. CH was white. So what does that mean? That this rare event in which all the stars seem to align correctly for a person to be maintained on medical treatment for opioid use disorder after incarceration was white, and not the race that we would expect in this situation, given the demographics of the incarcerated population in Baltimore. What it tells me is that while this encounter was indeed a success story for this one patient, it's not really a success story for our healthcare system at large. And by not expressly understanding the role that this person's race is playing in his ability to get buprenorphine, we might be missing the fact that a significant amount of privilege, both social, racial, and financial privilege, allowed this person to have this positive outcome. And a few minor tweaks to our healthcare system here or there really might probably not cut it for the patients I was more accustomed to seeing. So the case for me was highly reminiscent of this JAMA research letter that was published about 1.5 years ago now. It showed that buprenorphine prescriptions nationwide were highly concentrated among white people and those with private insurance. It was also reminiscent of this second article by medical anthropologists Helena Hansen and Julie Netherland, which argues that buprenorphine was purposely associated and marketed towards less stigmatized suburban white populations to achieve its legalization as a treatment for opioid use disorder, and that this media representation of buprenorphine has had profound effects on who receives the drug today. So taken all together, my takeaway was that we need to stop assuming that we know what type of treatment will work for people of different backgrounds from ourselves, specifically people of color who use drugs and are incarcerated. And rather than assuming things, we should just ask them directly. So pretty much this is what I decided to do when I then moved to San Francisco for my addiction medicine fellowship. I designed a research project to try to understand what the current barriers are to buprenorphine access during incarceration in San Francisco jails, as well as after release. So now for kind of the research aims of this study. quickly before we talk about aims, just defining the problem. Nationally, nearly 2/3 of people incarcerated have a substance use disorder of some sort. The US criminal justice system disproportionately targets underrepresented minority patients. In the first 2 weeks post-release, there is an overwhelming risk of drug overdose compared to the general population. One study found it to be 129-fold. Data has repeatedly demonstrated that medications for opioid use disorder during jail and prison is safe and efficacious for the treatment of opioid use disorder, and it reduces the immediate risk of death following release from overdose. Yet, very few prisons and jails have adopted the use of medications for opioid use disorder, and even fewer offer effective linkage programs at reentry. So locally here in San Francisco, Black people comprise less than 6% of the total population, but over 40% of those incarcerated, and that number is actually a little bit higher than it was back in 2016, 2017. San Francisco Jail Health Services started offering buprenorphine for the treatment of OUD with kind of varying models, varying eligibility criteria and protocols, starting nearly 15 years ago. So it's probably one of the first jails to offer buprenorphine to any patients. So that's actually pretty impressive. Yet fewer than 10% of patients started on buprenorphine were retained in care 1 week post-release. And that's based on internal data from OBIC from June of 2019. And OBIC is this clinic in San Francisco that is in relatively close vicinity to the jails, where jail providers refer people to continue bup if they are started on it while they're in jail. So many factors probably play into this, but there's really a dearth of data to inform the design or implementation of potential interventions to improve this. So what does the current state of medication for opioid use disorder access look like in the San Francisco jails? There's basically two kind of broad types of patients who might present to jail and need treatment for OUD. The first is people who are already on buprenorphine or methadone or naltrexone and have a regular prescribing provider or OTP, opioid treatment program, in the outpatient setting. And this group of people is continued on medications for OUD while they're incarcerated. And at the time of release from jail, they follow up with their pre-existing OTP or primary care provider or other buprenorphine provider. The second and much more common phenomenon is that a person with a clear history of opioid use disorder will be brought to jail and they're in withdrawal, but they're not regularly being prescribed medications for opioid use disorder treatment outside of jail. And the current protocol for these patients is that they're offered a 5-day taper of buprenorphine when they enter jail to treat their physiologic withdrawal symptoms. Then, depending on kind of how long they're in jail, they're during the bulk of their incarceration, they're maintained off of any opioids. And then if they have a known release date from jail, Jail Health Services will offer to reinitiate patients 2 weeks prior to their release, after which they can follow up at the OBIC clinic for ongoing buprenorphine as outpatients if they want to. So really the major issue with this model is that very, very few people are actually aware of their release dates from jail. And most people are released kind of same day from court, and they have no way of knowing prior to their release when they're going to be released. And certainly the doctors and providers in jail are not privy to that information, which makes it really hard because most people who qualify for starting buprenorphine in jail in this way aren't actually getting on buprenorphine before they leave. Okay, so with all of that, the aims of this study were to understand the lived experience of and barriers to treatment of opioid use disorder during incarceration and reentry, to explore how barriers might differ for people of color, and to use patient narratives as a guide to conceptualize improvements to opioid use disorder treatment in jail and at release. So just briefly, we'll go over the methods we used. We interviewed people who met these inclusion criteria. They're English speaking, over 18 years old, either currently incarcerated or recently incarcerated. And we'll it's really due to COVID, which we'll discuss. They had to have an opioid use disorder diagnosis per assessment by jail health services. And so for recruitment, kind of in the pre-COVID era, we were actually conducting these interviews probably starting the very beginning of March, end of February of 2020. And so as you can imagine, got kind of cut in the middle with everything kind of closing down for COVID. So recruitment pre-COVID, flyers were placed in the jail pods or living units to advertise the study. And interested patients would notify jail health services directly. Jail health services providers would also offer study participation during routine visits and keep a list of their interested patients. And then participants would be called down to the medical unit on the morning of the interview dates. We interviewed like 1 to 2 people per a half day. Informed consent in interviews were performed in a private exam room and recorded on an encrypted device. So modified recruitment due to COVID, after pretty much after the first week of March, we started, we no longer went into the jails to do this. We posted flyers at OBIC, the clinic that many people are referred to, as well as the street medicine clinic at 50 Ivy Street, where many patients who are coming from jail also frequent. And we offered $50 compensation for doing an interview. In this case, informed consent and interviews were conducted over the phone. So we conducted 10 total structured interviews with people with opioid use disorder with active or recent criminal justice involvement. And these interviews were then transcribed and then analyzed through a grounded theory methodology with 2 independent coders using an iterative process. Okay, so I'm gonna briefly provide you some results from this study. So the demographic overview of the people we interviewed for the study are kind of on this slide. Please just keep in mind that this is by no means a random sample of people. These were people who wanted to speak with us, and the majority of these people were incarcerated and recently started on buprenorphine within 2 weeks prior to their planned release. Or they were people that self-identified as just really wanting to help create positive change in the process of opioid use disorder treatment in the jails. So that said, about half of the patients we interviewed were between the ages of 25 to 35. About a third were Black, 50% were white. Of those 5 patients who were white, 3 were non-Hispanic and 2 identified as Hispanic or Latino. 2 patients were Native and 3 identified as a different race. Nearly half of patients were Hispanic, 4 out of the 10. And then in terms of length of stay, people had been incarcerated. People had been incarcerated for kind of varying amounts of time. The majority of people had been in jail for less than 3 months, but there was one patient who'd been there for nearly a year, another patient who'd been there a few years at the time of our interview. Okay, so from our grounded theory analysis, this is the basic framework that we've conceptualized from the data so far. So over the next 20 minutes or so, we'll kind of zoom into each of these analytic subcategories and present some of the data that led to the development of this theory. Okay, so starting just very broadly, the jail experience exacerbates addiction. So what exactly do we mean by that? So addiction in some ways can be thought of in the context of supply and demand. Part of what creates an addiction to drugs or a substance use disorder is supply, actual vicinity and proximity to drugs, and relative ease of access. This is certainly something that exists in jail and is exacerbated by being in jail. But in addition to the rampant supply of available drugs, there's really a significant exacerbation of the individual level of demand for drugs in jail, because the underlying causes of addiction, including trauma, isolation, racism, overall kind of negative self-narrative, all of these things are exacerbated for people while they're in jail. So some quotes that stood out from these interviews: this is like something that multiplies all the feelings you had on the street because you're in a box. You're dealing with family, court, your case, whatever it might be. And so everything is amplified and people want to get high. When society tells you that you're a piece of shit, you start to feel like a piece of shit, you know? this is not going well, that's not going well. I can't keep a family, can't keep a job. It's like society tells you that, you start to feel that. This is the worst place for me. Right here is where I feel my lowest, like I'm scum of the earth. So clearly jail is a place where people, if anything, are more likely to want to use drugs rather than less likely. And in that context, we learned from these interviews that some of the current policies being implemented are pretty problematic, specifically policies related to opioid use disorder treatment. Some of these policies were and kind of procedures at large were unintentionally promoting systemic racism, and others were actually probably increasing the likelihood of people, quote unquote, abusing buprenorphine during incarceration. So what do I mean when I say policies are unintentionally racist? So if the policy of jail is to allow people to be on buprenorphine maintenance only if they were already on it, and we all know that white people are more likely to have interfaced with the healthcare system prior to entering jail, the system is unintentionally favoring white people who are just more likely to have been on bupe to begin with. And so one thing I learned from these interviews is that the majority of people of color who I interviewed said that jail was the first place they encountered and learned about buprenorphine in the course of their lifetimes. They hadn't seen a provider outside of jail who's really talked to them about it. They didn't even know that there was medications to treat this other than methadone. So one Black patient, when they first arrived at jail, they were pretty young, and when they were in withdrawal, they said people kept on trying to pass me their bupe, trying to pass it to me. At the time, I didn't know anything about it. And he kind of goes on to say, to explain that when he was interviewed by the jail health staff and they were asking him about any illicit drug use, he said no, because why would he want to incriminate himself? Not knowing that there might be some sort of treatment available. And kind of along the same lines of that, people of color are just less likely to self-disclose their opioid use upon entry to jail. So another patient kind of remarked that, similar to this other patient, like, when you first come into jail, they're going to ask you, have you been using heroin? You're like, hell no, man, what the F? No, who are you? People get scared. When you got the nurse sitting in front of you and she gets surrounded by cops and she asks you, you're like, nope, I'm sober as a goat. So those are two different patients, but kind of the same idea from both of them. In addition, there was just kind of this general lack of advertising of the existence of a buprenorphine program in jail, largely also disadvantages people of color because it introduces significant risk of bias with individual providers making subjective decisions about who may or may not be a good candidate for buprenorphine. And the less kind of transparent you are about the program, the more likely there is to be some bias involved, even though none of us want there to be bias. So one white patient who was not initially put on buprenorphine when he first got into jail, but was started on it a few days later, they said, I asked for it several times, and then finally one of the RNs brought my case up. One of the RNs here was sympathetic to my cause because he's known me for a few years. This just happened to be a white patient. It could have been a Black patient who had known this RN from prior incarcerations and was offered to start on bupe because of that. But I think you can just get the picture here that this is just happening more for white people, and it's not intentional. Okay, so not only are current policies and unintentionally racist in some circumstances, some of these policies also unintentionally and paradoxically increase the likelihood that people in jail who have an opioid use disorder might abuse buprenorphine. This is in part because the lack of buprenorphine maintenance in jail encourages people to find buprenorphine in other ways. So one patient said, I snort it. I understand that's not what I'm going to do. That's why I wanted to get it on my own, so I don't have to continuously do it the illegal way. So the reason he's snorting buprenorphine is because if you're going to get diverted buprenorphine from other people in jail, basically what that looks like is somebody half consumed their buprenorphine tablet and then spit it up and added some usually powder from another drug, often Tylenol or aspirin, to kind of make it look like a pill again of some sort. And then they'll sell that, and the person who buys it will kind of crush it up. And then really the only way they have to use it is to snort it, because they don't have, other drug, other ways to use their drug, other supplies in jail. So this guy really doesn't want to snort buprenorphine. He was actually just put on bup the day before I interviewed him by Jail Health Services. And so I was really grateful that he was able to do it sublingually thereafter. Another patient said, I was with no Suboxone there by legal terms, meaning he was not getting Suboxone. Granted, I still had Suboxone, but I was getting it mailed to me. I had my family, people I know, they send it to you under the stamp. And so two patients had told me that they had gotten buprenorphine mailed to them somehow in jail. And kind of along these same lines, I guess shifting gears a little bit before we go there, people also continuously reported that this 5-day taper upon reentry was not particularly effective, especially in this new era of fentanyl use and increased withdrawals that people are experiencing when they come off of fentanyl in comparison to heroin or any other opioid, really. So one patient said, but I would still feel sick like after the 5 days is up. It's like fentanyl is really intense when it comes to kicking. Another patient said the taper system does not work because it's like it takes away you kicking and all that, but what about afterwards? You're not fully addressing the issue. So what he's really alluding to is buprenorphine might not, while it is certainly helpful and isn't kind of low-hanging fruit in terms of things that can be offered in jail, it's not really addressing the underlying issue. And what he's looking for is really therapy or groups. And there'll be another slide on kind of elaborating on that a little bit further. Okay, so this last issue that kind of came up in this category came up a number of times, and I found it really interesting. Basically that buprenorphine reinitiation can cause a high for people, and this is problematic in jail. So we in addiction medicine, we always tell our patients that buprenorphine makes you feel normal and not high, given that it has this partial opioid agonism. But when we say that, what we really are referring to is the process of starting buprenorphine once you already have a high opioid tolerance and are coming off of a full agonist opioid. When you're starting from a much lower level of opioid tolerance after being completely off of opioids during any period of time, for example, like a prolonged incarceration, according to many of the people that we interviewed, people do get high. And this can be really destabilizing, even if they're taking it correctly, correctly underneath their tongues and doing kind of what they're told. And this is probably not what we want for people who are about to be released, is for them to kind of feel destabilized with this new feeling or right before they're leaving. So one patient was pretty blunt about it. I mean, they say, oh, Suboxone don't get you high. They don't get you high because it's a blocker. They do realize that's a bunch of BS. I hope they know. Another patient was kind of specifically referring to the 2 weeks, really. So 2 weeks is the reinitiation period. You're still high when you get out on Suboxone. Not long, just like if you don't do nothing for like 2 weeks, then get put on, it's a good feeling. That holds up for like 3 weeks, sometimes longer than that. So I feel like 2 weeks isn't enough for it to build up. A different patient said, when I'd be in jail for like 2 months and then not using, and finally I would obtain some bup and then use it, it would get me high. And then kind of in contrast to that, he says, I've used it for 1.5 years. This is outside of jail. And it doesn't do that for me anymore. All it does is help me with the cravings, what it's supposed to do. So really that second part is what we're aiming for when we start people on buprenorphine, is for them to be able to use buprenorphine to focus on other things and not necessarily to kind of confuse the picture right before they leave jail, which I don't think was the intended plan by anybody when they created these policies. So the second kind of cluster of analytic subcategories I wanted to discuss has to do with opioid use disorder being a chronic disease state, and that therefore it should be treated as such, and ideally should have like a multimodal programming surrounding its treatment. So the first theme that we'll explore is one that was brought up in literally every interview, that early treatment initiation increases the likelihood of post-release success in continuing buprenorphine. So this theory stems from two basic ideas. The first is that buprenorphine is stabilizing for people with opioid use disorder. It's very stabilizing, particularly in jail. So when you're on buprenorphine in a situation like this, you're able to kind of prioritize things that should be more important. Like, how am I going to end up, how am I going to not end up back here? What are my plans for getting into a program or whatever? Rather than, all right, how am I going to use when I get out? So the second idea here is that being on buprenorphine for a longer period of time during incarceration just increases the likelihood that people are going to stay on it afterwards. So what one patient said was, if you were to get put on Suboxone while you're here to build up your habit of it, that would help, because then you get out of jail and you need to use Suboxone. It's a part of your daily routine. It's a habit now. And if you get put on a couple of days before you get out, it's not going to do much. And then similarly, this is a patient who, different patient, he said, I've never spent more than 3 months out of jail at a time since the age of 13. So now that I'm 25, I spent the last year and a half out of jail. And so to me, buprenorphine is amazing. He'd been put on buprenorphine during his last incarceration, and it was started a little bit before 2 weeks prior to his release. And that's what got him to be basically sober for a year and a half and out of jail for a year and a half for the first time. It's probably not the only factor, but it's one big factor that he identified. All right. So this next theme that I wanted to explore was focused on how transitions out of jail can be improved by increasing the visibility and publicity of the buprenorphine program in jail. So many patients indicated that they felt like people in jail, including themselves, despite being on buprenorphine at the time of these interviews, didn't actually have a lot of understanding of how buprenorphine worked or what to expect from it. And so one quote was, if you fully educate these people, tell them everything about it, people would be more likely to stay on it. And I think what this was really stemming from is there's a lot of talk around buprenorphine in jail, but it's a lot of hush talk, it seems to me, from these interviews, because he didn't really want to be caught talking about it, because then people would think that you're doing something funny and diverting or planning to divert or whatever. And so they wouldn't talk to their providers about it in their appointments. But then there wasn't a lot of education outside of that. And so that's just by making their whole program more visible and more transparent, that a lot of that could be addressed more easily. Another issue at the time of reentry was that there was all sorts of logistical issues that came up in making it to appointments. Even if people did have a basic understanding that they should be presenting to the OBIC clinic or any one specific clinic. So this is a quote from somebody who was kind of sporadically actually initiated on buprenorphine throughout his incarceration, had been on it for like a month and a half during incarceration, even though he was initiated. So it was kind of an exception. And then he was discharged to a residential treatment program. So he said the appointments was filled up. He was talking about appointments at OBIC. I had to wait a week to be in quarantine at the program he was in, then do the OBIC stuff. I'm like, I'm not going to do this. I'm having somebody to give me Suboxone. I got directed to somebody, bam, paid them off, cash them out, $90. So basically what he's saying is that he got really frustrated with the system right when he left jail and not having access to buprenorphine in any kind of conceivable way that fit his circumstance. So he just bought it from somebody, which is, not, it's interesting. He spent $90 when really he could get this for free if he was able to see a provider, and we made that more easily accessible. finally, kind of the most common report from patients in regards to how the transition process could be improved is that people just really need to be on buprenorphine prior to their leaving jail. So giving them like a discharge prescription, or even like handing them some buprenorphine at the time of release, if they haven't already been started on it, is not going to be nearly as effective. I think a quote that strikingly conveys this is, buprenorphine really knocks out an enormous hurdle for me. The hurdle being, I get released out on 7th Street, and I walk down the street, and literally I know 50 people that will give me free drugs when they see me, just because I'm fresh out of jail. It's a hard hurdle to jump over if I'm not on bupe. What if I take my dose that morning? It would prevent me from, not just from overdose, but from using in the first place. Okay. So we spent a lot of time talking about buprenorphine specifically. As I kind of alluded to earlier, one of the findings from the study that was intriguing was that patients really wanted more than buprenorphine. They're really serious about wanting to use their jail time to create lasting change. And this might just be, the subset of patients that really wanted to talk to me. And so many people that we spoke to were asking for psychosocial programming in addition to buprenorphine. So the takeaway here is that while bupe felt to be like a necessary part of treatment for most patients, and it's again kind of likely the lowest hanging fruit as far as costs and ease of access to administer in jail, buprenorphine was generally not thought of as enough on its own. So many patients voiced interest in therapy in groups. One said, but when I asked for therapy, I was told that I can't because I'm not a psychiatric inmate, which didn't make sense to me at all, because how the hell am I supposed to be rehabilitated? You need to address these problems of why you have an opioid problem in the first place. So pretty insightful, and kind of makes a lot of sense. There's reasons that their jail isn't able to provide therapy for everybody, but just something to consider. Another kind of quote along the lines of therapy. So once they start to release those demons, I feel like they will actually be able to release that habit. And a lot of people self-medicate because of problems, not knowing that me dealing with it, how I deal with it, is actually killing me. So when he's talking about releasing demons, he really means being in a therapy setting. Every patient that I spoke to also kind of interestingly mentioned kids or family members as a large motivating factor for them, which was not something that I had really thought about too much. And I hadn't really thought people would be discussing that while they're in jail, just because they're not really around their family members. But because it was like brought up so frequently in these interviews, I think that there might be some creative ways to use this value and this like idea that family is a very strong motivating factor towards to our advantage in designing future treatment programming. So what one patient said was, so he's talking specifically about buying drugs in the black market in jail. He says, this time, no, I wanted to be no part of buying other drugs because I was on Suboxone and they gave us free calls. So every time I came out, I got on that phone and she ain't playing. So she is his partner, the mother of his children, and just having that more frequent communication with her because calls were free, I guess, during kind of the COVID surge was hugely beneficial to him. Okay, the last topic I wanted to discuss was this idea of diversion, because diversion is probably the #1 concern that people from jail health services understandably have in making buprenorphine more accessible within the jails. So the theory that emerged here was really that diversion, yes, is going to be an issue. And people were pretty blunt about this. However, they also noted that it's an issue that's not at all singularly about buprenorphine. And it should therefore not be an issue, not be the defining reason of why the buprenorphine program in jail is or is not expanded. So diversion should really be looked at from the lens of risk-benefit analysis. So one patient said, yeah, there are always risks, but I think like anything, there's pros and cons. In my opinion, risk of new onset addiction. So basically, one of the concerns is if you divert to somebody who doesn't already have an opioid use disorder, they might develop an opioid use disorder, and that will be kind of on that will be the fault of jail health services by giving some people bupe. So in my opinion, risk of new onset addiction is much less than like the people it's helped. So I think if you weigh it out, the benefits are greater than the risks. Another patient said, nothing's going to be 100% perfect. That's why we try to get as close to it as we can. What if they stopped giving it continuously the way they're giving it now? I can tell you this for a fact, I can still get my hands on it. So this idea kind of just alludes to this next point about there just being accessible other drugs in jail, including buprenorphine. So if it's not for more buprenorphine to be available in the jail, there's going to be some other drugs. And pretty much every patient also said it was easier to access non-bupe drugs than it was to access bupe, either legally or illegally while they're incarcerated. So even if bupe was diverted, it's better than basically any other opioids being diverted. So one of the people that we talked to said, but it is what it is, that kind of thing is never going to be avoided, like drugs getting into jail, just because people are crafty, they figure it out. Finally, kind of knowing that diversion is going to be an issue, many patients identified specific efforts that could help reduce the risk of diversion. So one idea that came up a lot was just to develop a stricter protocol. So kind of an umbrella kind of quote for this entire theme that came up a lot was, I understand you divert, you need to cut off. That's understandable. So a lot of people were saying, just give people the benefit of the doubt. And if they divert, then totally cut them off because that's not appropriate, or in their mindsets. But that it shouldn't be a reason to shy away from giving people bupe to begin with. Another theme that many voiced was just like process changes to like how pill call is handled for buprenorphine. So one person said, I would probably have those particular inmates come out of their dorms and down to medical and have them take their medication in those areas. Show me your mouth afterwards, maybe drink a little water afterwards. So obviously any sort of process changes like that, if you're going to move the place that they give people this specific drug, that's going to create a lot of logistical issues probably for the jail, but this as well as kind of just more protocolized processes for evaluating whether people actually took their buprenorphine were brought up a lot. People said they'd rather have that, even if it's kind of annoying to them, than to not have buprenorphine at all. Finally, the overwhelming thing that people had to say about diversion was that it would be far less likely to happen if there was just sufficient access to buprenorphine for all comers for the treatment of opioid use disorder that was like unmanaged. So one patient said, I diverted a few times. I was just with friends of people that I knew who were just coming in. They were in a position I was in. We all know how it is to be dope sick, and it's really bad. It's really ugly. So some of this diversion is just to treat other people who aren't getting treated in the ways that they need. And then another patient said, because no matter where you go, you're going to have these little frigging idiots. I mean, I'm one of them. People sell it and I'm going to be here to buy it because they don't give me enough. Like when I first got in, I wasn't on anything. So, if they're not getting treatment somehow, they're going to get it another way. That is the point here. Okay, so based on these interviews, there's a few interventions that we proposed. All the interventions actually on this page have already been implemented. So the first was just like implementing a bridge buprenorphine supply at the time of release to bridge them. So prior to this study, prior to them implementing this bridge buprenorphine supply and prescriptions, people often were like released on a Friday night and then told to go to OBIC on a Monday or Tuesday and didn't have any buprenorphine between that time. And they were, if they were started on buprenorphine, they're almost certainly withdrawing at this point. So really, really hard to make it 72 hours or even like 48 hours after being dosed with bupe to get your next, then be in a program where you have to enroll and then get your next dose. So to kind of overcome that, just giving people a bridge prescription at the time of release. So they started doing this in November of 2019 in the form of like a prescription. And then a couple months later, they started giving a 3-day dispense supply on property to people who, again, had a TX date or had a date of a release from jail. And now, just over the past few months, they've started implementing not just 3 days, but 5-day prescription that they give to people as soon as they start buprenorphine in jail. And then for people that have a known release date, also a 5-day dispense supply on property. So really just increasing that kind of wiggle room to bridge to another program. The other intervention that's been implemented is a referral flyer at the time of reentry to diversify follow-up options. A lot of people identified that, OBIC is great in a lot of ways, but doesn't really fit everyone's needs, and sometimes it's kind of higher barrier than they're willing to kind of deal with at the time of reentry. So this referral flyer basically has locations, hours of intake, accepted insurance options for all low threshold bupe sites in San Francisco. And just a few months ago, people at Jail Health Services updated it and kind of made it better to include other information such as overdose prevention information. Finally, one intervention that we thought of kind of a while back was just to switch from the sublingual tablets of buprenorphine to films, because it would just decrease diversion really, but also it would decrease the time for monitoring at pill call. And they actually did do this over the past few months. Unlikely to be directly related to this project, but I think just with spotlights on it and kind of increased discussions on this topic, they are using sublingual films. The biggest barrier to that is it is more expensive, but it's something that the jail has decided to invest in. Some other proposed interventions. So buprenorphine maintenance throughout incarceration is brought up repeatedly in these interviews. And I found out just yesterday that they made a decision yesterday to start piloting this in June of 2021, so very soon. And then having a post-release peer navigator to support in accessing locations where they can get buprenorphine when they leave. And there's currently a grant being written for this by the medical director of OBIC. And the next steps would be to increase awareness of the buprenorphine program. I think people are still trying to figure out a way to standardize the eligibility criteria. Should there be a urine drug screen at intake? Should people be having to meet certain criteria of withdrawal? Something like this that's more transparent would just reduce stigma and improve access to the program. It would also kind of encourage the perception of buprenorphine as a medication rather than a potential drug of abuse. Finally, and this is, I think, one of the hardest things to implement in a setting like this, but because it was mentioned quite a few times, just considering adding groups therapy or social networking of some sort as an adjunct to just buprenorphine for the treatment of opioid use disorder. Okay, so very quickly, just our take-home points. Existing opioid use disorder treatment policy in San Francisco jails perpetuates systemic racism, increases risk of abuse of buprenorphine. The expansion of the buprenorphine program in jail may provide significant benefits, but also weigh risks. Many novel interventions are currently underway. It's a very exciting time, and patients with lived experience are certainly the best experts when it comes to all of this. And that's about it from me. So I will take any questions you have now. I'll stop share screening.
So Nicky, thank you very much for the talk. It's really, I think, illuminating in many different ways. And I also just wanted to reflect that it's quite impactful to have this intimate view of as you're looking at what people's experience is at the intersection of addiction, criminal justice system, and systemic racism. I think it's quite impactful and quite important to be impacted by it. While we're waiting for more questions to populate, I wanted to ask you to lead off with, I couldn't help but think as you were giving your talk about long-acting injectable buprenorphine, and I was thinking about it in terms of some of the issues you mentioned, particularly the issues with diversion, problems with withdrawal following a 5-day taper, and the issues around the first 2 weeks when people leave the setting of incarceration and they are at risk for overdose and may have discontinuity of their buprenorphine. Comments or thoughts about that?
Yeah, no, thank you for bringing that up, Brad. So that actually was, when we're initially creating this interview tool, is something that we asked patients specifically about. The biggest issue, I think, with long-acting injectable buprenorphine, Sublocade, is that it's super expensive, and all these drugs are paid for by the jail itself to give to people, and that was kind of the biggest barrier to sublingual bupe from the tablet form. So that's one of the barriers there. But in terms of when I actually talk to people about what their thoughts would be about this, a lot of people, first of all, had never heard of it before. So whenever you haven't heard of something, it just sounds scary. And people don't really love this idea of getting an injectable once a month. It kind of feels like, similar to like long-acting antipsychotic injectables, like somebody's doing something to you that you can't really control. And people identified that, like, a lot of people getting their dose of buprenorphine every day or a couple times a day is important for them because it's like a ritual. And getting a dose of Sublocade or long-acting injectable is going to take that away. So it might be less effective in that way. It also, in the context of jail, I think there is part of it is, physiologic, and this craving that happens when you don't have access to opioids. But I think part of it's also, especially for people who start using drugs when they're in jail, is this kind of boredom, and they're kind of looking forward to something every day. And in that way, Sublocade is less appealing as well, I think. But that said, I know they've piloted something with Sublocade or long-acting injectable at the San Mateo jails, and I think it's being like kind of more permanently implemented now. It was on a grant, so they're having some success with that. And I do think that there's so many benefits to it. When I was first designing this project, that was like the first thing I was thinking is like, long-acting injectable is really the ideal here. And I think there's some studies on that as well at RIDOC and other places right now.
Thank you. That's really interesting. It sounds like a lot of the same problems that we experience in the non-correctional setting in introducing long-acting injectables. Okay. Mm-hmm. You talked a lot about structural issues in your talk. Can you say something about some of the structural barriers that you have encountered in trying to implement these buprenorphine-related interventions that you're trying to do in the jail setting?
Yeah. So I think I personally have not, I don't work at jail health services. I have a number of colleagues who do, and are working really hard to change the system there. I think one of the things I've heard has been really difficult in implementing, particularly the buprenorphine maintenance change, is many years ago when opioids were kind of more being prescribed as the fifth vital sign for pain, there was a lot more opioids being prescribed in jail, and a lot of people, there had been some overdoses associated with that. People would kind of store their opioids and then take them all at once, whether it was intentional or not. And I think there's been basically a lot of trauma for providers from that. And a lot of those providers are still working at the jails. And so when buprenorphine kind of came along, even though it's a partial agonist and we know nearly on its own impossible to overdose on for an adult, it's still an opioid, and it still kind of carries with it that same concern for a lot of people that just is a little bit triggering. So I know one of the issues, and this is not something that I really had to interface on my own, but that I've just heard from providers there, has been kind of culture change around having more availability of buprenorphine. And I think, as an outsider to jail, as an outpatient provider myself, we know that buprenorphine is being diverted in the community, and our response is kind of like, well, they're treating somebody else's opioid use disorder. And I think that's less permissible in jail for a lot of reasons. And there's more reasons to think that might be more problematic. There's this concern that buprenorphine might turn into like a currency if it's like super available. And that was, I think, the case with other opioids back in, 10, 20 years ago when it was, there was more opioids in the jails. So I think, culture change in regards to making buprenorphine more available have been pretty difficult, but understandably so.
Thank you. I think we're nearing the end of our time, but there's some really, really very wonderful comments coming through in support of your talk. And then there's also a question. Can you speak about any insurance issues that come up? Reactivation of health insurance and access to care medications. Any perspectives on how these gaps are addressed locally in the Bay Area?
Yeah, so that's actually an interesting question because I thought that was going to be like the number one problem with people coming back into the community when we first started doing this. So I guess when I was, a fellow, I was kind of in this process of helping kind of implement some of these changes, like the earlier changes, the bridge supply. And when we were doing the bridge prescription, my concern was that nobody was going to get this filled because it wouldn't be fillable because people didn't have Medi-Cal activated. And surprisingly, that has not happened. People are going to like Walgreens and getting it filled. And I don't know if I don't honestly completely understand why that's possible. Medi-Cal maybe just not unactivated because they're in jail for such a short period of time or what the issue is. But that's been kind of favorable. Other insurance issues, certainly if you're in jail for a long period of time or if you, many, like I think 60% of patients, I think is what I heard, who are in jail in San Francisco are actually residents of San Francisco. So many people are coming from other counties. And so then they're not going to be able to access medications when they leave as a prescription, which is part of why they're working hard to give people a dispense supply, even though that is kind of more complicated and more expensive for them, just to make sure that they have the access to this bridge.
Thank you so much. I think we're coming to the end of our time. There's some just wonderful comments about the excellent grand rounds and a lot of thank yous. And so maybe that's a good place to conclude with thanking you so much for this work. A comment coming through, thank you, this was amazing. So thank you, Dr. Mehtani, very much for this talk. And I think that we are now at the close. Thanks everyone for coming to join us today.
Thank you all for joining us. Have a great rest of the day.